Hello, everybody, and very good evening. My name is Saima Asgar. I'm Director, ISA Pakistan Chapter. And on behalf of ISA Pakistan Chapter and ISA Global, welcome you all to join this very important topic on a very important webinar on a very important topic. And for this, many of us knows that ISA Global has been started a series of webinar on new psychoactive substances. And this second webinar among the webinar series is going to be hosted by ISA Pakistan chapter. And this webinar will focus on synthetic hallucinogens, synthetic depressants. And for this purpose, we have been invited two of our very experienced panelists with us. The first panelist is Professor Fabrizio Schifano from UK. He is going to share an overview of new psychoactive substances, its definition, and a brief history. He will talk about its typology, and we will also learn about its medical uses, effects, withdrawal, and addiction. He will also talk about its treatment as well. And our second panelist is from Pakistan, Dr. Syed Azhar Ali Khazmi. He will also talk about new psychoactive substances. Specifically, with Pakistan's perspective, he will give a bird eye view of addiction scenario in Pakistan, specifically for these class of substances. Specifically, with Pakistan, he will also discuss about the challenges being faced in Pakistan due to these new psychoactive substances. He will talk about solutions of these challenges as well. But before we start our formal presentation, I would like to share that as usual, you all have been muted to avoid background noises which may distract you from learning to the webinar. But if you may have questions in your mind or want to comment about the topic, you can use the chat box and send your question and comments there. And I would also like to share that interpretation of this webinar is also available in Russian language. So the people who join this webinar from Russia, they can also use this channel as well. Now it's time to introduce our panelist. And our first panelist is from UK.
Okay.
Sorry. No, it's time to introduce our very experienced and familiar personality from all across the world. And I must say, he is the bank of knowledge about today's topic. And he is Professor Fabrizio Schifano. He has done his MD. He is a fellow, Royal College of Psychiatry, and a chair in clinical pharmacology and therapeutics, consultant psychiatrist, University of Hertfordshire, pharmacology, drug misuse, novel psychoactive substances, research unit, School of Life and Medical Sciences, UK. And today he's going to talk about recent changes in recreational drug scenario, synthetic hallucinogens and synthetic depressants, clinical pharmacological and psychopathological issues. So once again, welcome Professor Fabrizio, and over to you, sir.
Thank you, Saima. Thank you for the organizer. Saima, is it visible? My slides, are they visible?
Yes, let me check.
Yes, they are, Professor. Yes, they are.
Okay, I'm going to put in the full screen now. Okay. So thank you again. So yes, today we are talking about the synthetic hallucinogenic drugs and the synthetic depressants. But more than prior to starting our conversation, we need to discuss about the psychonauts and the e-psychonauts, because this topic, this kind of user, they are very important for our research. The first time that the psychonaut term was introduced in the literature was in about 50 years ago by Junger, who was referring to psychonauts as those people that are doing just psychoactive drugs, I'm just quoting, with the intention of achieving greater knowledge of what he called the inner universe, the psychocosmos. I see a number of psychonauts in my clinic. I have my clinic here in the northern part of London in Hertfordshire. And quite a number of the clients, they do navigate the internet, they navigate the web, and they do acquire medication, they do acquire drugs, and then they do discuss about these issues online, which are the personal key skills of the e-psychonauts. They are called e-psychonauts whenever they are mainly based on the web. So first of all, they do have an open-mindedness to the exploration of the inner soul. So basically, they do take drugs and psychotropics because they want to explore the inner soul, what we call them entactogenicity. Then they do have, the psychonauts, a sense of community and sharing their own experiences. Basically, if you do enter the typical psychonaut websites, you do have detailed trip reports with the dosage combined with the psychological effects. But it is very important and very relevant that the e-psychonauts, they do distinguish very strongly from the culture of the so-called druggies, the junkies, they say here in England. And also, they do have an open-mindedness and availability to take part in scientific research discussion. They call them the chemical researchers, if you like. Overall, there is a very interesting, very important psychometric scale, which is called the Temperament and Character Inventory by cloning, the TCI. If you want to, from this point of view, you can conclude that the psychonauts, they do have very high levels of impulsivity, but very low levels of harm avoidance, and very strong levels of sensation seeking, for the very simple reason that they try to achieve a lot of sensations, if you like, with this kind of drugs. Which are the typology? We have distinguished in this paper from Laura Orsolini, with Laura Orsolini was one of the tutees here in Hertfordshire, the psychonauts in two groups, the chemical experimenters and the navigators of the mind. The navigators of the mind, they do use drugs in order specifically to explore the frontiers of the mind. On the other hand, the chemical experimenters, they do test the chemicals in order to document the drug's effects and to assess whether it is safe for others to use. These subjects perceive themselves as doing it in the name of what they called the psychedelic research. If you think that this is not relevant, this is extremely relevant, because at the moment, even in the general mainstream psychiatry, there is a lot of debate about the psychedelic research. Here I am going to show you, because what we are doing together with a number of colleagues in Italy and other European countries, what we are doing, we have, if you like, built up and implemented a web crawler. A web crawler, it is an informatic tool which is navigating 24/7 for the last 27 or 30 months, navigating on a list of psychonaut websites. So basically, to be able to understand exactly what the trends in terms of novel psychoactives are, we are not waiting for the novel psychoactive being seized, maybe in Pakistan or in Italy or in England, because we believe that whenever a novel psychoactive is being seized, is being identified in the field, it is probably already very late, because whenever the police, they are able to seize a molecule, a chemical, it means that there is already an enough concentration of that molecule around in the field, in the territory. So to be able to understand exactly which are the trends in terms of the novel psychotropics, we basically monitor 24/7 the discussion of the psychonauts in their own websites. To cut a long story short, we have been able to identify in this way something like in excess of 4,300 molecules. I do repeat myself. According to our database, and this is being updated at the moment as we are sitting here, we have in the web a discussion about at least 4,300 molecules. It is very interesting that, of course, we are going to comment on these 4,300 molecules today. And the topic of the discussion today is the synthetic hallucinogenic drugs and the synthetic depressant. It is very interesting that the psychonauts, as you can see from here, 30% of the molecules, you will see better in the next slides, they are psychedelic phenethylamines they are discussing, but also another category which is extremely relevant for psychonauts. It is the novel synthetic opioids, which is another group of sedatives, another group of depressants. So in other words, the topic today, it is extremely relevant. As you can see from here, it is exactly the same slide in a different position. So in terms of synthetic cannabinoids, you do have about 1,250, but in terms of synthetic psychedelic phenethylamines, we are going to see better in a few minutes, you do have in excess of 1,260. Also, you do have the synthetic opioids. We have been able to identify something like 460 different synthetic opioids. But it is interesting here, if you have a look to the GABA A, GABA B receptor agonists, you do remember better than myself that benzodiazepines, for example, which are the typical sedatives, they are GABA A, GABA B receptor agonists. We have been able to identify something like 172 molecules of this group, but we are going to comment better in a minute. As you can see from here, this is the more specific, if you like, list of the molecules which are being commented in the psychonaut websites. Those which are relevant for us today, they are those possessing a 5-HT2A related psychedelic activities, but also those that they do have a sedative properties. Let's start with the psychedelic activities. So first of all, in the first statement here, in the first line, you do have the 179 MDMA-like drugs. In this group, which was first described by Alexander Shulgin in 1972 and published in 1991, of course, you do have the MDMA, but also have the MDA, the MBDB, the PMA, PMMA, etc., the 2CB, which is called Nexus. So in a nutshell, you do have 179 psychedelic amphetamines. But it is of interest and very scary as well that the latest generation of psychedelic phenethylamines, they are not working in milligram like the MDMA-like drugs, but they are working in micrograms. Microgram, as you know, it is a millionth of a gram, a millionth of a gram. It is very interesting, the group of the NBOMI that you do see here. For example, you do take the 25 CI, which is a very old psychedelic phenethylamines, which is typically classified, scheduled, and working in milligram, which is 1,000 of a gram. And then you do add the group NBOMI. So you do have the 25 CI NBOMI. Here it works in milligram, but the 25 CI NBOMI works in micrograms. Basically, and it is an extremely powerful compound, which is typically being sold and acquired as LSD. So they are extremely powerful. Then you do have another compound, which is a derivative, which is the bromo dragonfly. The bromo dragonfly, it does take, I'm telling you because from the clinical point of view is very relevant, this debate. Basically, you do take the bromo dragonfly now at 2 o'clock in England, but the effects, the lag time of the onset of the effects will be deceiving at 8 o'clock in about 5 or 6 hours. So at the beginning you think, oh my God, I took something which was a fake tablet. And so as a result, to get high, you start taking ketamine and cocaine and LSD, etc., etc. but 6 hours later, the brown dragonfly will kick off. And so as a result, in your body, you do have a range of drugs already. But it is of interest that whenever the brown dragonfly will start kicking off, it will last in the system for at least 3 days. And these people, they are extremely clinically sick. Then you do have a group of LSD-like structure, like, for example, the LSA, the 1P-LSD, ALD52, etc., etc. In this group, which are the LSD-like structure, you do have about 30 or 35 compounds. Later on, we are going to discuss about the synthetic opioids, but what I wanted to tell you, to show you here, a range, because the second book, which was written by Shulgin, was in 1997. The first one was called the PICAL, the phenethylamines I have known and loved, while the second one, 1997, it was called the TICAL, the tryptamines I have known and loved, and it was describing something, a few doses of tryptamine derivatives, something like the 5-MeO-DALTE, the alpha-methyltryptamine, the 5-MeO-alpha-methyltryptamine. All of these compounds, they do have hallucinogenic-like activities, exactly 5-HT2A related receptor activities. The latest book from Shulgin described, which was published in 2011, about 10 years ago, described the situation of something like 126 novel psychedelics. However, he was commenting about a further 1,300 molecules, including the DMAA, which is called the geranamine. It is of interest that a few years ago, a nice lady, about 40 years old, at the end of the marathon, she died. She had a myocardial infarction on the London Marathon, I mean, the 42 kilometers. And she was found that she had ingested DMAA, which is being sold on the web as a stimulant. And there are other compounds that I do have hallucinogenic-like drugs. Of course, we are not going to comment on all of these compounds today. I'm going to focus on those that I do have hallucinogenic-like activities. But if you do like, apart from ketamine that you do know very well, there are quite a number of derivatives of ketamine. And I would like to point out about diphenidine, methoxyphenidine. These two compounds are very much the focus on the UK scenario at the moment, but also dextromethorphan. Dextromethorphan, of course, I'm not going to comment on the commercial name of the different medication, but this is an over-the-counter compound, antitussigen compounds, and whenever you are taking 7 or 8 bottles of this dextromethorphan, which is called also the green triangle, you do have hallucinogenic ketamine-like activities. Another element which is extremely relevant for our debate today, it is the ingestion of herbs and plants to achieve 5-HT2A related psychedelic activities. For example, the Salvia Di Minorum is not working on the 5-HT2A, but it is working on the kappa decay opioid receptor, the mu and the delta, but more than anything else, decay opioid receptor. We are going to see the salvia later on in the slides. So Salvia Di Minorum, which is not the Salvia officinalis, the sage, okay? And then you do have the Mitragina speciosa kraton. We are going to comment later on. This is an opioid compound. Then you do have Ibogaine. Ibogaine can be found in Africa, in some parts of Africa. And the Ibogaine, it is the typical 5-HT2A psychedelic compound. Then you do have Kavakava, which is another very relevant compound that you do find in the Fiji. This does have a sedating compound. And then another one which is extremely well known, at least in Europe and in Brazil, it is called the Ayahuasca, Psychotria, Viridis, and you will see later on the comments that we're going to make about ayahuasca. And then you do have the hydrangea, which does have a similar to cannabinoid compounds. And then you do have the Magnolia officinalis, containing the magnolols and honochols, they do work not only on the GABA receptors, but also they do work on the cannabinoid receptor. And then, of course, the datura stramonium, which is a typical anticholinergic compound. Once again, you can have hallucinogenic experience. And then you do have a number of psychedelic mushrooms, but also like Amanita muscaria, Inochibe, Conochibe, Panaeolus, Stropharia cubensis. Of course, it is also possible to achieve 5-HTA psychedelic activities from the ingestion of or the licking of the skin of specific animals like the pufo or the Sonoran desert toad, or another one which is called cambo, that we are publishing a paper now. And then you do have a number of sponges and specific flights, etc., etc. But more recently, we have been able to emphasize the need to focus as much as possible, I do repeat, as much as possible on the misuse of the range of prescribing medication. What happened? As you know, in most of the countries in the world, over the last couple of years, 3 years, there have been something which is called the lockdown. During the lockdown, especially here in England or in other European countries, it was very difficult to go out. It was very forbidden. Even the dealers, they were not going out. So it was difficult to get the normal heroin and cocaine and LSD. So the people, they were referring to the medicinal cabinet, trying to take advantage of what it was available from the medicinal cabinet to get a recreational high. So basically, from this point of view, during the COVID, definitely we have observed all over the world an increase in the misuse, the very strong misuse of prescribing medication. I'm going to comment on some of them. For example, here in England, we see a lot of tramadol and oxycodone. We're going to comment on remaining opiates later on. Gabapentin and pregabalin, they are massively misused in England, but also in other European countries. Benzidamine, benzidamine is a very well-known antiseptic, over-the-counter antiseptic, which is typically, whenever it's going to be ingested, although it is not going to be ingested, whenever it's going to be ingested, you are going to have hallucinogenic experiences. And then in terms of psychotropics, prescribing psychotropics with very high doses of venlafaxine, something like 600, 800, 900 milligram, you do have the activation of 5-HTA receptor as well. It is also possible to misuse with bupropion, but in this case, you do have dopaminergic activities. And then most recent papers, including some paper published a few days ago, pharmacovigilance paper, they have absolutely emphasized the need out of all antipsychotics, the possibility to misuse with olanzapine and quetiapine. According to the Psychonauts, the ideal psychedelic trip terminator, it is exactly the olanzapine. But myself as a clinician, whenever I start olanzapine, I start 2.55 milligram, and then slowly or increase to 10 milligram, 15 and 20 milligram. The Psychonaut, they take 50 milligram today, 50 milligram tomorrow. If it is working, it is working. Otherwise, they are going to the A&E. The other element, the other antipsychotic, which is of extreme interest in this scenario, it is called also quetiapine, which is an extremely well-known antipsychotic. It is a very good compound, by the way, but whenever it is being misused, it is called the Q-bomb. First of all, you need to be aware that quetiapine, whenever it is going to be misused, is not going to be ingested, but typically it is being snorted. So it is not the quetiapine extended release, the prolonged release, if you like, which is being misused, but the immediate release, because the quetiapine in the extended release, the molecule, the medication, it is adhered to a number of pairs, if you like. And since whenever if you start snorting, if you try to snort the extended release, the psychoactive effects are not there. So basically you're snorting very high dosages of the immediate release. From the next slide, just a second. We have published a number of papers. Of course, these papers and other papers, they are exactly available for you as long as you write to myself. Another element that we are observing at the moment, it is not only the intake of a single medication of a single molecule, but there is a polypharmacy use. For example, at the beginning of the night, ecstasy or other psychedelic hallucinogenic drugs, whilst raving, they are ingested in association with alcohol. In this way, you do have stronger physiopathological effects. After a few hours, the effects of ecstasy and other psychedelic amphetamines, they are going to disappear. So you are going to take in the middle of the night cocaine, stimulants, additional ecstasy tablets to maintain the arousal. But then at the end of the night, whenever it is the time to go home, you are going to take very high dosages of opiates or alcohol. Now it is being used as a sedating compound. So the typical night out, the raving night, if you like, it is not described by the ingestion of one medication or one molecule only. On a typical night, people are using 4 or 5 different psychotropic. This is the history of one of the psychonauts from here in England. I have divided in uppers, downers, and all-arounders. Uppers, he was taking cocaine, amphetamines, and Ketamine. The downers, as you can see from here, he was taking benzodiazepine, opiate, alcohol, barbiturates, and Kavakava. In terms of all-arounders, the psychedelics of today, he was taking LSD and mescaline, dimethyltryptamine, IAG, Ayahuasca, the phencycline, the ketamine, MDMA, MDA, cannabis, and Ibogaine. So most of the molecule that we have mentioned in the previous slides. Another, maybe you don't see very well from here, I can show you another one. 17 years old, he was taking MDTP, methylenedioxypyrovaleron. He was taking bath salt, which this is a synthetic ether, and then he was taking the methadone, another synthetic cathinone, and then the dimethocaine, which is another stimulant, which is cheaper than cocaine, but with the longer effects. And then it was taking the APDB, which is similar to the benzofurid that we have mentioned before. And then he was taking the NRG2, which is a derivative of a synthetic cathinone. And then he was taking the MDAI, which is instead of the meow meow, which is the methadone, it is another synthetic cathinone. So you can see from here quite a number of different molecules that the people they are taking. This is the PICAL we have mentioned before, the 179 phenylethylamine we have known and loved. This is exactly the reference book, if you like, for those producing the synthetic molecules. Which are the ecstasy-like drugs that we mentioned before? We do have the MDMA, which is the parental compound of MDMA. Remember that all of the ecstasy-like drugs, all of them, they do work more or less on dopamine, noradrenaline receptors, noradrenaline receptors, but also on the 5-HT2A receptors. Some of them, they are more stimulating. Some of them, they are more hallucinogenic effects. As you can see from here, just out of 179, we're going to mention the MDA, which is the love drug, the MDEA, which is Eve, the MBDB, the 2CB, which is called Nexus or pink cocaine, the BOD, which is going to provide yourself with 16 hours of inner strength, the DOB, reported to be 33 times more powerful than MDMA. Then you do have the flatliners for the 4-MTA, but also the 2CT7, which is the blue mystique, which is one of his personal favorites. But these are, exactly as I said, the entactogen and pathogen. I do repeat myself. Entactogenicity, it means that you are in better contact with your inner soul. Empathogenicity, it means that you are in a better contact with the external world. This is the second book, the TICAL, and then you do have the Shulgin Index. For example, have a look. This is a classical slide which I've presented several times. It is very, very different. If you are not, just a second, because the light, just a second. Okay. Now have a look to this. This is one of the entry from the Psycho website. They say, similar to combine the DMT, DPT, 5-meo DMT, these are derivatives of the TCAL with ketamine. If you do combine the 4-hexatoxyl diethyltryptamine with ketamine, also this will provide you with an incredible synergy. This is going to be highly recommended for the cosmic mystical, which is basically the tryptamine, if you like, because they are called entheogenic drugs as well, but also near-death inclined, because basically the ketamine is going to give you a near-death experience, and the cosmic mystical is going to be provided by the tryptamine. If you don't want to take that, you can take xenon gas, wild mushroom, or LSD, which is going to come close seconds. As you can understand from here, the discussion of the cyclone, they are very, very complex, and they do require a lot of dedication, if you like, because these kinds of chronic, they can be sometimes very difficult to be remembered. Now we're going to talk about, we are just discussing about the entheogenic and the shamanic compounds. For example, here, in terms of the most popular entheogenic and shamanic compounds, in terms of synthetic drugs, you do have the PCP-like derivatives, but also the LSD, 1P-LSD and LSA-related derivatives, and the range of psychedelic phenethylamines. In terms of plants and herbs, we have already mentioned the Ayahuasca, Ibogaine, Datura, Mitragina speciosa, San Pedro cactus, Lamanida muscaria, and Algireia nervosa. Chair, do I have another few minutes or no? Hello?
Yes, you do. Go ahead,
Okay.
Professor.
Yes.
Thank you very much. This is methoxyethamine. I'm going to show you some example. Okay. This is ketamine, because methoxyethamine, it was just deriving from ketamine, because it was felt that ketamine was very toxic for the blood, the urological system. So they were providing the customers with methoxyethamine from special K to special M. But the result was that apart from the urological toxicity, methoxyethamine does possess as well central nervous system toxicity. This is a little bit of neurobiological elements, as you can see from here. This is the ventral tegmental area. All of these drugs, they do work basically increasing the level of dopamine in the shell of the nucleus accumbens. They do it directly, like for example, most of the stimulants, or they do that indirectly. For example, the opioids, they just interact with the mu receptor, which is in the GABA neuron. So the GABA neuron, which is typically inhibiting the dopamine turnover, if you are going to interact with the mu receptor of the GABA, okay, you're going to stop the GABA from working. And so you do have an increase in the dopamine turnover. In a nutshell, which is exactly the same schematic element, which is being carried out by the cannabinoids and the synthetic cannabinoids, as you can see from here. This is exactly here. You do have the THC of the synthetic cannabinoids interact with the cannabinoid receptor, which is the GABA neuron. The GABA neuron with this interaction is going to stop working. So you do have more dopamine stars which are being released and interact with the postsynaptic dopaminergic receptor. This is the typical cannabinoid receptor. We are not going to discuss a lot about the cannabinoids today. This is one of the synthetic cannabimetics. It is very scary because you do have different components. This is going to interact with the cannabinoid receptor. This is going to interact with the 5-HT2A receptor, and this is going to interact with the NMDA receptor as an antagonist. So basically, in a single molecule, you don't have only the CB, the cannabinoid ligand, but you do have different kind of activities. And on top of that, here there was the hydrogen, but to increase the level of depophilicity, there was they included the fluoride. So the passage of the blood-brain barrier, it is much easier. So today, of course, all of these medication and molecules, etc., they are associated with a number of side effects and psychopathological consequences, because most of the compounds that we have mentioned, either they are dopamine agonists or they are partial, like marijuana, or full agonists, like the synthetic cannabinoids. We have discussed a lot about a range of 5-HT2A agonists, but also we have discussed about the PCP-like compounds like ketamine, methoxyethamine, diphenhydramine, methoxyphenidine, and also we have discussed about the K-opioid like the Salvia Di Minorum. I'm going to show you something because we need to discuss about the depressant, because opioids in the Western world and in England in particular, they are really exploding. This is a paper we published a couple of years ago. Okay, have a look to how many opioids are being discussed in the psychonauts world. For example, the methylene dihydrodesoxymorphine, it is 80 times stronger than morphine. Then you do have bromadol, you do have cyclazocine, which is more than a mu delta, it is K opioid receptor. Then you do have cyprenorphine, similar to buprenorphine, but you do have dysphoric and hallucinating properties. Then you do have krypton. Krypton, it is the oldest methyl tramadol, which is exactly the main metabolite of tramadol. Most of the people, they do misuse with tramadol, thinking that tramadol per se, it is a prescribing opioid, which is not very strong in terms of opioid receptor activity, but actually the main metabolite, which is the oldest methyl tramadol, is extremely powerful. Then you do have embutramine, which has been used for suicide by people that do access the drug. Then you do have levalorphan, levomethorphan, which is, you remember that we have discussed about dextromethorphan. However, the main issue that we do have at the moment in terms of opioid, they are the fentanyl derivatives. You want to remember that a fentanyl per se, it is 70 to 100 times more powerful than morphine. Fentanyl, you can find that in the patches which are going to be adhered to the skin. But you do have some derivatives like carfentanil, which are 100 times more powerful than fentanyl. So you do have a potency which is 10,000 times more power than morphine per se. And then we have been able to identify, and we have described as well, the derivatives of omephentyl, OHME, which are 6,300 times more powerful than morphine per se. Okay, going to show you something else. It are synthetic hallucinogenic drugs, another 5 minutes. They do give you hallucination, illusion, pseudo hallucinations. Okay. These are the psychedelic phenethylamine with the 2C compound that we have mentioned previously. Sorry if I'm going to rush, but you know, as you can understand, discussing about 4,300 compounds in a few minutes is very difficult. These are the N-bomb-is. Of course, the sites are going to be in your pocket. These are the psychedelic treatments like the TICAL. And now this is Salvia Di Minorum. It does contain salvinurin A and B, which we said it is a K opioid receptor agonist, which means that it is a short but intense hallucinogenic activity plant that has been used as a shamanic inebriant. This is the ayahuasca, very well known, ayahuasca. It is a combination, this is a sort of a mixture of the derivatives of Banisteriopsis caapi, where you can take the beta carbolines, but also the Psychotria viridis. So basically, whenever you're putting the Psychotria viridis with the dimethyltryptamine, the dimethyltryptamine is going to be metabolized by the digestive system. So you are going to include the Banisteriopsis caapi beta carbolines to be able to inhibit the catabolism. This is the Caratum mitragina speciosa. Sorry if I'm rushing. It does contain mitraginin, 7-hydroxymitraginin, mitrafillin, and O-desmethyl tramadol. Okay, this is very popular in some southern Eastern Asia countries. This is Ibogaine, which is a mixture, if you like, of KOPR receptor agonist, but also, once again, it is an agonist of 5-HT2A receptor, but also an MDMA receptor. It's a similar, it is a combination of Salvia Di Minorum, psychedelics, but also ketamine. Very interesting compound, but very powerful as well. This is Datura stramonium, very, very popular in some countries. It is an anti-hallucinogenic, it is an anticholinergic compound, okay? And this is psilocybin. You do have 200 different fungi, psilocybe, conocybe, Panaeolus, Stropharia, they do contain psilocybin, okay? Okay, if you at the moment there is a lot of debate about the psychological and psychopathological and sought after effects, but basically you do have a very strong influence of the mindset and setting with the psilocybin and related compounds. You do have better impactogenicity levels, but also you do have an open eye visual perceptual disturbances, but also strong alteration of the time subjective experiences. The minutes, they are going to be hours. Okay, remember that at the moment a number of issues with the intake of psilocybin have been described, apart from self-harm, bad breath, but also the HPPD, which is the hallucinogenic persistent perceptual disorder, apart from the depersonalization and derealization. There is a lot of debate at the moment about the psilocybin use as an antidepressant. Psychiatry, there is a lot of discussion about that. They have described recently psilocybin as well as this breakthrough therapy, but possibly it is an issue which is beyond the capacity of this debate today. These are the illegal toad venom, which is one of the recent trends, and this is the dextromethorphan, which I was mentioning before. Okay. In a nutshell, whenever the people they are presenting to the A&D, it is unlikely that urine specimen is going to be identified as positive one or more substances. So to be able to control the aggression, to cut a long story short, the benzodiazepines are possibly the most likely, the most helpful compound. However, I will leave these slides. To you. For the psychopathological disturbances, once again, the possibility of using the benzodiazepine or otherwise the second generation antipsychotics. I will stop here. Thank you for your attention.
Thank you very much, Professor Fabrizio, for sharing a very wonderful and comprehensive presentation with us. And we are also requested you to stay with us because after the next presentation, we have question and answer session. And I received a wonderful comments about your presentation from our audience as well, but have few questions. So we request you after the next presentation to answer that question, please. Thank you. And now I'm going to introduce our next panelist. He's very young and committed young psychiatrist from Pakistan, Dr. Syed Azhar Ali Kazmi. He's consultant psychiatrist, head Department of Psychiatry and Behavioral Sciences, Poonch Medical College, Combined Military Hospital, Rawalakot. He's the Provincial Secretary, Pakistan Psychiatric Society from Azad Jammu and Kashmir. And today he's going to talk about synthetic hallucinogens and synthetic depressants. Specifically, he will talk about trends in Pakistan. So from us, Pakistan, and as a global welcome, Dr. Azhar Ali Kazmi. And sir, over to you to share your presentation, please.
Hello, everybody. Saima, can you see my presentation?
Yes, sure. Sir, please continue.
Okay, hello, everyone. Today, I'm going to talk about a very important topic, that is synthetic depressant and hallucinogen from Pakistan point of view. And there is a quote about the hedonism. And to the hedonist, life is the avoidance of boredom and routine. And this avoidance from boredom and routine continues. And the continuing effort to this boredom and to this routine leads towards the invention of newer and newer drugs, including newer synthetic depressants and synthetic hallucinogens. Professor Fabrizio gave you a very beautiful and wonderful view about hallucinogens and depressants, their pharmacology and their classification, their way of action. And I'm going to tell you about briefly about the history about the hallucinogens, that it is one of the oldest substances that are used by humankind. And in 1930, a Swiss chemist, Albert Hofmann, synthesized LSD. And later on in 1950, that LSD was actually used with the brand name of Delicid in psychiatry to treat depression and other different psychiatric disorders. But later on in late 50s, they found that LSD not only have some dependence potential, but it is very hazardous to human brain and human health, and it also has some hallucinogenic effect. So they ban this drug. And in 1970s, benzodiazepine, they were one of the most prescribed medicine in the whole world. And in 1990s, the Z drugs, that is the drugs for to treat insomnia, zopiclone and esopiclone, they came in the market, and also the gamma hydroxybutyrate, which is also known as the rape drug. But to continue it, recently we can see, particularly after this pandemic in 2019, the COVID pandemic, we have seen the surge in this drug abuse all over the world. And this is the beautiful word used by used in the textbook of addiction, international textbook of addiction, that is syndemic. And it is the synergism effect. And synergism means the effect of the two, the bigger effect of the, that is the pandemic and the drugs. They are affecting people and affecting badly. So we are passing through a syndemic response after COVID-19. When we talk particularly about drug dependence in Pakistan, it is a different from other world because the designer's drug, the newer drugs, this is not our problem. Our problem is the main problem, the main issue is actually the older drugs, and that is our main issue is heroin and cannabis. About 8.5 million dependents, drug dependents, in 220 million of total population, according to United Nations Organization for Drug and Crime. They are in Pakistan, and 4 million of cannabis dependents. We are not talking about abusers here. We are talking about those population who are dependent on some drug. And 4 million heroin dependents, they are present in Pakistan. And in Pakistan, the loss due to this drug dependence is bigger. It's bigger due to joint family system, and it's bigger due to the stigma, and it's bigger due to the rejections based on the social and cultural and religious norms. In most of the religion sects followed in Pakistan, uh, the drugs, all the drugs, they are absolutely forbidden. And the people who use drugs, they are treated very badly, and they are rejected from the religious people and from uh, everyone. So not only they are rejected, their family, they also feel rejected. So due to a giant family system. So in Pakistan, we face the bigger loss in terms of drug users. And when we talk about the treatment facilities and the social support resources, we have a very few treatment facilities available, particularly in remote areas. We don't have any treatment facilities for SUDs. And in urban areas, we have very few professional treatment facilities available. And other important issues that we are facing in Pakistan are lack of budget. And we have less than 0.1% budget for mental health. And in the mental health, we are spending the lowest budget in SUD problems. So you can appreciate that the political will is nowhere. We have a very small quantity of a budget here for this neglected population. And one more important issue that we are facing in Pakistan, that we are far behind in scientific research. And when we search for any research regarding this SUD, we cannot find any, even for the prevalence of heroin or cannabis. There are surveys of UNODC, and apart from that, we cannot find any valid research in whole Pakistan. So we are lagging behind in scientific research. Talking more about Pakistan and the drug dependence, no specific, I have searched a lot, and no specific research was available on synthetic depressant and hallucinogen. And as we have discussed already about the syndemic after COVID-19 pandemic, problem has increased, and this is mentioned. This was mentioned in UNODC Drug Report 2021. And another interesting problem in South Asian population, and particularly in Asian population and in South Asia, including Pakistan, we have different ethnopharmacology. That is very different from West, from the Caucasian population of UK and Europe, from Russia, and from Americans. We have different liver enzymes, and there are many researches about difference in the enzyme aldehyde dehydrogenase, which detoxify alcohol and other enzymes in the enzyme, and it leads to the different tolerance different tolerance levels of the drugs and different responses of the drugs. The response of alcohol is very different here in Pakistan. That's why it is not very common. That's why it's not very prevalent in comparison to Caucasian population. The liver of Pakistani people, it gets damaged easily, and it gets damaged more, and it cannot detoxify the hazardous compounds found in ethanol easily as in the Caucasian population. So ethnopharmacology is also very different from those populations. I have a very interesting case of use of synthetic hallucinogen for you, and I am sharing with you with the permission of the patient. And it's 2 years back when I was working here in Islamabad in a tertiary care hospital, that a 24-year-old young man, he was brought to emergency of a tertiary care hospital in Islamabad with the self-amputation of his penis. And he was shouting, yelling, and using abusive words, and also bleeding. After his initial treatment and later on the reconstructive surgery of his penis by a plastic surgeon, he was evaluated in detail by a psychiatrist, and also by me. And I found that he was intoxicated on that day with LSD on a party. And after taking the huge quantity of LSD, he developed distorted perceptions and guilt about the sexual activity, resulting in self-amputation of his penis. So this was a rare case of this synthetic hallucinogen abuse that I saw 2 years back. The synthetic hallucinogen, it's becoming prevalent in Pakistan, and people are using it more and more, and it's not easily available in Pakistan. People they have to use the dark web and other concealed web sources for trafficking of these drugs, to import these drugs from the West, and like LSD and like PCB. But as the professor already described, ketamine, it's easily available in Pakistan, and its use or abuse has recently increased manifold as compared to the past. And it's a dissociative hallucinogen, and it causes dissociation. People used to inject it through intramuscular injection, and also take it in a little amount for through IV. So I want to show you a few slides about the ketamine. And this is from a very respected source from the Dawn newspaper, and a recent June 2nd, 2022, that a ketamine worth 210 million seized and by the Ministry of Narcotics. So you can appreciate that from this slide that the use of ketamine in Pakistan is rising day by day, and um, it's in the black market now. So there is another slide about the ketamine, about 34 billion uh, Pakistani rupees of ketamine found in the rose water bottle, and it was seized in Karachi, and that was this is a report of a respected newspaper, very valid newspaper, Tribune. And as a clinician, as a psychiatrist, we we have a ketamine clinic. We run it for depressive stupor and for bipolar depression that is not responding to normal medication. And recently, we have a shortage for this dissociative anesthesia in the market due to this trafficking in the black market of ketamine. So mostly we found that health professionals, anesthetists, because that is easily available to them, and pharmacists, and those people are involved in ketamine addiction in Pakistan. I'm going to talk about a very prevalent and a very huge problem in Pakistan, and that is the synthetic depressants, and that is the benzodiazepines. And I described in a survey which was conducted by ANF in 2013, that 1.5% of women and 1.3% of men, they are abusing benzodiazepine in Pakistan. And in Pakistan, not from the psychiatrist, they are more prescribed by the other non-psychiatric doctors like cardiologist, neurologist, gastroenterologist, and the general practitioner. And the problem is that once they are prescribed and people get relief from insomnia, from anxiety, they are not properly psychoeducated about its stoppage after 3 to 4 weeks. So people continue using it, and after 1 to 2 months, they found that they became dependent on it. So people are abusing. You can have benzodiazepine, you can have alprazolam from any pharmacy, even without any prescription here in Pakistan. The Z drugs, the hypnotics, they are also very popular, and they are also very easily available, and there is no proper regulation, no pharmacological laws are applicable in Pakistan. So you can have these drugs, and you can have pregabalin or gabapentin, and also barbiturate. So this is our bigger issue, and the newer depressants and the newer hallucinogens, they are not our main problem. And we are passing through benzodiazepine epidemic, and they are hourly prescribed. They are very cheap, and as I have already described that there is no regulation on pharmacies. That's why these drugs are easily available, and once started by a doctor, it will continue, and it will continue for months, for years, and even for decades. And another thing, and another interesting thing about benzodiazepine is that less stigma is attached with the use, with the abuse of alprazolam, chlordiazepoxide, or diazepam, or bromazepam, in comparison to other addiction like alcohol, like cocaine, like um, uh, ecstasy, like heroin, and in Pakistan. So, due to the less stigma, people can easily and readily use it without any fear. And similar is the case with pregabalin and gabapentin and barbiturates. And benzodiazepine has its abuse has recently increased, as with uh, you can see all other drugs after COVID-19. And the problem with benzodiazepine is that the withdrawal of benzodiazepine lasts for 3 to 6 months, and its dependence. As a psychiatrist, I have seen a lot of cases of uh, every drug, but I have found very difficult to treat uh, 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 benzodiazepine dependence, because the withdrawal can last for 3 to 6 months, and it's very difficult to treat. And I have recently saw a case of a female patient, and she was abusing 60 tablets of alprazolam at morning and 70 tablets of alprazolam at night. And it was a terrible case, and it was a difficult case to handle. This was a brief, you can say, a brief view of the depressants and the hallucinogens of Pakistan. And we have a lot of patients of heroin, but the newer synthetic depressants related to opioids like fentanyl and other, they are not very common and rare in Pakistan. What we need in Pakistan, uh, although ISAP is working, and ISAP has a main role in these SUDs and in this campaign, but we need more scientific approach and more professionals in this ISAP, and we need SIMA is very energetic, and but we need more energetic people to work for primary, secondary, and tertiary prevention of this epidemic in Pakistan. And we also need to have a liaison with the health department and with the government to allocate budget for this neglected but very important area. And we need destigmatization and awareness campaigns, and we are looking on these awareness campaigns, and particularly destigmatization. We need destigmatization stigmatization of our religious people, and on social basis. On every forum, we need destigmatization of SUD. And we also need the trainings of professionals, all the professionals who are working with SUD. They should be trained, and there should be a uniform way to treat this problem all over in Pakistan. And there is no regularization of addiction treatment centers in Pakistan, and we need to focus on the regularization of these addiction treatment centers, so the SUD treatment can become more fruitful and more can give more results. And most importantly, we need research in addiction, because without it, we don't have any prevalence studies, we don't have any studies about the effectiveness of any treatment modality. So we need research in addiction. So in the last, I must say that although we have a lot of challenges and we have a lot of problems, but as an ISEP team and as a drug professional, I must say that these challenges and these problems are the fuel of success. So thank you very much, Saima, for giving me the time. It was a brief view about the synthetic depressants and synthetic hallucinogens from Pakistan perspective. Thank you very much again.
Thank you very much, Professor Fabrizio and Dr. Syed Azhar Al-Kazmi, for sharing a very comprehensive and wonderful presentation on new psychoactive substances, especially synthetic hallucinogens and synthetic depressants as well. Now, on behalf of our audience, I have few questions and request you to answer some of these. So can I ask first question from Professor Fabrizio? Sir, Professor Fabrizio, can you hear me?
Yes, I can. Of course I can. Yeah. Can you tell me the question?
Thank you once again for the wonderful presentation, but I have a question for you.
Yes.
The first question is, why an explosion of novel psychoactives has been observed over the last couple of decades?
Okay.
Can you
Thank
please
you very
answer?
much. Yeah. Thank you very much for your question. It is very interesting. So, as you know, Dr. Saima, the recreational drugs, they were around anyway. MDMA ecstasy was available during the 80s and the 90s. But the reality is that during the second part of the 90s, both MDMA ecstasy and cocaine, the price went down, but also the concentration of MDMA and cocaine went down. And also these molecules, they were, and they still are, very illegal. So at the beginning of this century, some groups, they started proposing a number of chemicals which were synthetics. In this way, these synthetic chemicals, for example, in terms of synthetic catenones, instead of proposing to you the cathinone from the cat plant, they were proposing the synthetic catenones or the synthetic psychedelic phenethylamines and so on and so forth. So the NPS overall, they are lookalikes to the classical recreational drugs, MDMA, heroin, cannabis, benzodiazepine, prescribed medication. But typically they do have two characteristics. Number one, in most of the countries, they are not illegal. Number two, it is very difficult to be identified in the urine specimen. And number three, the potency, it is extremely high, very, very high. From this point of view, thank you, Dr. Azar, for the presentation of the case report from the Islamabad hospital, the client who amputated the penis. But for example, it was mentioned in LSD intake, but in a typical accident emergency, it would be very difficult to get a dosage of the LSD in the typical A&D. So you are typically relying on the report of the client. Was he taking LSD? Was he taking one of the LSD derivatives? He was taking ketamine, he was taking the embalming. We don't know. We are relying on the words in good faith of the client himself.
Yeah.
But you must admit that it is all, that's all what we have, because in a typical London hospital, they are not able to identify more cannabis, morphine, cocaine, amphetamines, alcohol. Even if you want to look for ketamine, you need to send to the forensic labs. So in other words, you do identify 5 compounds out of about 4,300 compounds.
Yeah.
And on top of that, in most of the countries, please correct me if I'm wrong, Dr. Azar, in most of the countries, most of these NPS, they are not illegal. If I am a bus driver, if I am a doctor, if I am a nurse, and I'm taking something, a synthetic cathinone, they're not going to catch me. But if I do take cocaine, they're going to catch me immediately. Is that correct?
Yeah.
So that's why the explosion of the NPS over the last couple of decades. But Dr. Asghar, the problem that I do have, which is, it is a question that I don't have an answer because my head is exploding. Why the people are taking such powerful compounds? If I do take carfentanil or a derivative which is 10,000 times more powerful than morphine, the possibility that I am going to die, it is very high. It is not negligible. Do you agree with me, Dr. Azar?
Yeah.
That's a question that I do. I don't have an answer. It is not only sensation seeking, it is the levels of harm avoidance are nil. In other words, the people are thinking, give me the night, give me the whole night as if there was no tomorrow. Give me something so my head is going to explode. I don't bother about what is going to happen tomorrow. Don't tell me anything about my retirement, my pension, my family, whatever. I don't want to hear about that.
As I have mentioned that hedonism, the pleasure-seeking behavior, it has no limit, and it continues. So this can probably the answer of your question that why the people they are taking the much more potent drugs.
So there is a sense of boredom.
Yeah.
Yeah, which is very relevant. And from this point of view, the COVID has not helped because it was giving you a sense of helplessness, hopelessness.
Yeah.
Everybody was closed, locked down at home, and they were asking, when is it going to finish? 6 weeks of further lockdown, 6 weeks of further lockdown. 6 weeks, we came to 16 months.
Yeah, very right.
Thank you very much, Professor Fabrizio, for a very detailed answer to question of our audience. And my next question on the behalf of audience is for Dr. Azhar. And the question is, as you explained the joint family system in your slides, has this any relationship with drugs?
Sorry, say again. Can you repeat?
Actually, this question is for Dr. Azhar, and I'm going to repeat this again.
Dr. Azhar. Sorry about that.
Sorry. Dr.
Okay.
Azhar, my question. The question is, as you explained the joint family system in your slides, has this any relationship with drug abuse?
Okay. Very relevant and very important question from Pakistan perspective. We have a joint family system here, and joint family system has many positives in Pakistan. that it gives you an emotional support, a financial support, but it also a bigger stressor in terms that you have to satisfy the emotions of your mother, your sisters, and you have to satisfy the financial needs of your brothers and financial need of your own children, financial need of your wife, and also the financial need of your father and mother. So it's a two-edged sword here, and it is a big stressor. And one of my teacher, one of my professor, he used to say that in Pakistan, the people, the females that come with the depression, the biggest etiology, the biggest cause behind that depression is ontological issues. Means the issues related to these joint family system. So the stressor behind this joint family system can lead to the abuse of drug, and it is a one of the it can be a predisposing factor or a precipitating factor for drug dependence, particularly in Pakistan.
Thank you very much. I hope this will be a satisfactory question for our audience. And the next question is for Professor Fabrizio once again. Sir, can you please share that why are sedatives and psychedelics so popular globally?
Okay. First of all, opiates. In the Western world, we are in the middle of an opiate epidemic. There are some countries, including England, for example, it is very difficult to be prescribed with benzodiazepine by the GP surgery, but it is not at all difficult to be prescribed with an opioid. You can go to your GP, you complain of back pain, and basically it is not very difficult at all to be prescribed with codeine, triacylcodeine, cocodamol, etc., etc. On the other hand, if you want to be prescribed with benzodiazepine, it's more difficult. Here in England, for example, the market of the designer benzos that I did not have the time to comment on extensively before, as you know, diazepam, alprazolam, etc., etc. These are the medications which have been mentioned by Dr. Azar as well. But at the moment, we have identified more than 100 designer benzos. So the people, including my clients here in Hatfield, Hertfordshire, they are entering the web and taking from the web a vast range of benzodiazepine compounds, which is extremely relevant, but some of them, they're very powerful. Like, for example, pirazolam, it is 12 times more powerful than diazepam. Phenazepam, it is 5 times more powerful than diazepam. But we have recently published a couple of papers and making presentations, scientific presentation, in which we have been able to demonstrate that some of these designer benzos, they called also exotic benzos, they do have an activity at the level of the opioid receptors as well. So, and also, whenever Dr. Azar was mentioning alprazolam, you remember you were mentioning alprazolam.
Yeah.
Here in England, they have made some calculation in the Wedinos, which is a very important organization in Wales, that whenever you buy alprazolam, so-called alprazolam from the web, it is alprazolam actually only in 42% of the cases. So 60% of the cases, impossible. I do have a client here in Hertfordshire, is purchasing benzos from the web, is going to the A&E twice or 3 times a month. Apparently, allegedly, he's ingesting only 3 tablets of so-called alprazolam. How can you go to the A&E with just 3 tablets of alprazolam? Not even the cat is going to the A&E with 3 tablets of alprazolam. There must be something else which is far more powerful. Was I able to express myself, Dr. Saima? So in other words, the word of the MPS it is derived from the classical recreational and prescribing medication. But the reality is that the web is offering the customers those medication, those molecules that a customer are attracted to. Another issue which is very relevant at the moment, they are called the smart drugs, smart drugs. The people, they want to be bright, they want to have a beautiful memory, concentration, attention. They are studying medicine, they are studying engineering. They study a lot, but they want to remember a lot. They are already very intelligent, but they want to understand more. So they try to ingest medication from the web like modafinil, methylphenidate, amphetamine salt to increase or allegedly increase their levels of the cognitive levels, the cognition enhancers. We have recently published a paper about that. So, Dr. Saima, the world of the MPS at the moment is really exploding. And in my opinion, the web is offering the customer exactly what they want. If you do think hard, during the lockdown, during the COVID, everything was closed down. But the Royal Mail, the postmen, they were working all the time. The logistics, they were delivering packages every single day to every single house. So you could buy anything from the web, including medication and IPS, which is exactly what was happening. So in other words, the COVID, believe me, has not helped at all. And also the mental health of the individuals went downhill. Anxiety, depression, suicidality. Can you confirm, Dr. Azar? At least this was the situation in Europe. The people, they were not happier. Who told you that the lockdown is beautiful? It's not beautiful whatsoever, the lockdown. The mental health, especially of the vulnerable individuals, went downhill, including family crisis, definitely. Alcohol went sky high, medication is, oh, disaster, disaster. Okay, I hope I was able to give you an answer, Saima. I hope I'm not too pessimistic, but this is exactly what I say every single day.
That was very detailed and very well answered, sir. Thank you very much. We have 2 more questions, but we have very limited time to close our webinar. So, on behalf, first of all, on behalf of ASA Global and ASA Pakistan, I would like to thank both of our speaker guests, Professor Fabrizio and Dr. Saeed Azhar Ali Kasmi, for having with us and sharing your wonderful presentation and your precious time to join this webinar. Thank you very much.
Okay.
And thank you. And I would also like to thank our audience for joining this wonderful webinar and sharing your productive feedback and wonderful compliments for our speaker guests as well. Thank you, dear audience, once again. And on behalf of ISA Global, on behalf of ISA Pakistan chapter, my team and President ISA Pakistan chapter, I would like to thank all executive board of ISA Global for providing us this wonderful platform to share knowledge, especially the evidence-based knowledge about substance use prevention, treatment, and recovery support as well. I specifically thanks to all as a global team for always providing us technical and moral support, especially Ma'am Jonna, Miss Livia, Miss Ola, Miss Olivia, Miss Diana, Mr. James, and all who always support and motivate us, guide us to have these wonderful initiatives for all our professionals across the world. Thank you very much. I would also like to share for our audience that to successfully attend this webinar, they can get certificate through the email, and they can download from your email as well. And the recording of this webinar will also available on our website and our YouTube channel. So who could not join this webinar today, maybe they have some reason, so they can learn from the ISA website and ISA YouTube channel. I would also like to repeat ISA website, that is www.issup.com.
Okay.
You can also join us. Thank you very much once again.
Okay, thank you very much. Bye-bye, bye-bye.
Thank you so much, everybody. Thank you, ISA team, and thank you, our guest speakers. Thank you, sir.
Thank you very much. Thank you very much.